हाँ, तो बाइट चेक हम सीख रहे हैं कि हाउ टू चेक द ऑक्लूजन फॉर अ सिंगल मोलार क्राउन विच इज़ द मोस्ट डन ट्रीटमेंट इन द क्लिनिक। तो क्यों कर रहे हैं? क्योंकि सबसे ज़्यादा जो भी प्रॉब्लम्स होते हैं डेंटिस्ट्री में, इट इज़ बिकॉज ऑफ नॉट सेटिंग द ऑक्लूजन प्रॉपरली। ऑक्लूजल डिजीज़ इज़ द मोस्ट कॉमन एंड मोस्ट प्रॉब्लमेटिक डिजीज़ इन द डेंटल पेशेंट। एंड अगर हम क्राउन एक ऊंचा लगा देते हैं, थोड़ा ऑक्लूजन सेटल नहीं होता है, कुछ लैटरल फोर्सेस आता है, तो क्या होता है, टूथ के ऊपर एक्स्ट्रा प्रेशर आने की वजह से कैप निकल सकता है, कैप चिप ऑफ हो सकता है, वर्टिकल रूट फ्रैक्चर हो सकता है, री रूट कनाल की भी ज़रूरत पड़ सकती है, पेशेंट को पेन हो सकता है, टीएमडी भी हो सकता है, मसल स्पैज़म भी हो सकता है। पेशेंट जनरली अवॉइड फिर कर देते हैं यहाँ खाना, दूसरी साइड से खाना स्टार्ट कर देते हैं, तो यूनिलैटरल च्यूइंग की वजह से प्रॉब्लम्स हो सकती हैं। बहुत सारी डेंटल रिलेटेड प्रॉब्लम्स या टीएमजे रिलेटेड प्रॉब्लम स्टार्ट बिकॉज जिस डेंटिस्ट ने कैप लगाया वो ठीक से चेक नहीं किया, ऑक्लूजन ठीक से देखा नहीं, और उसकी वजह से वो प्रॉब्लम आ रहा है। ठीक है, सो हमारा काम अच्छे से लास्ट करें, हमने जो पेशेंट को दिया है वो प्रॉपरली आई थिंक काफ़ी साल चले, 5, 10, 15 ईयर्स चले, यही हम सब चाहते हैं। और इसका कितना भी अच्छा रूट कैनाल करें, कितना भी अच्छा हम मार्जिन्स प्रिपेयर करें, बॉन्डिंग करें, लेकिन अगर कैप आए ना तो सब वेस्ट हो जाता है। तो हमें ये बहुत इंपॉर्टेंट है कि ऑक्लूजन अच्छे से चेक करके भेजें। तो अभी हम देखेंगे कि कैसे चेक करना है। इसमें स्टेप 1 इज़ कि पेशेंट जो परसीव कर पाता है, परसेप्शन कैसा है, अगर हाई सेंसिटाइज्ड पेशेंट है, बहुत सेंसिटिव पेशेंट है, तो वो हमारे लिए एक्चुअली अच्छा है। ये डेंटिस्ट को लगता है कि कैप लगा दिया, कैप लगाने के बाद इमीडिएटली पेशेंट ने बोलना चाहिए हाँ एकदम ठीक है, परफेक्ट है, मुझे कोई प्रॉब्लम नहीं है, घर चले जाए। लेकिन वो एक्चुअली पेशेंट्स ना डिसीविंग होते हैं, उनको समझ में नहीं आता है कभी कभी कि कितना ऊंचा है। और अगर थोड़ा सा भी ऊंचा रह जाए और परसेप्शन हम पेशेंट की बात मान के छोड़ दें कि इट इज़ ओके एंड वी डोंट चेक इट प्रॉपरली, देन इट कैन कॉज प्रॉब्लम्स, इट कैन कॉज फेलियर्स। जो पेशेंट्स बहुत सेंसिटिव होते हैं और थोड़ा सा भी ऊंचा रहे या थोड़ा सा भी बल्कि रहे, उनको फील होता है और वो डिमांड करते हैं कि इसको एडजस्ट कर दो, वो बेटर पेशेंट्स हैं बिकॉज वो हमें फीडबैक दे रहे हैं। वो सेंसिटिव पेशेंट्स अच्छे से डिटेक्ट कर पाते हैं छोटी छोटी चीज़ें, और उससे हमें ही फ़ायदा होता है, हम ही बेटर हो सकते हैं। फिर हम और ज़्यादा चेक करेंगे और फिर हम एक्चुअली ऑक्लूजन प्रॉपरली सेट कर सकते हैं। ठीक है, पॉज कर दे। क्या करेंगे हम, जैसे हमारे पास ये पेशेंट है, आज हमने कैप लगाया, फॉर एग्जांपल मान लो 4-6 में हमने कैप लगाया। सबसे पहले हम पेशेंट को पूछेंगे और एग्जैक्टली ऐसे ही वर्ड्स में बोलेंगे कैप लगाने के बाद, ऑब्वियसली प्रॉक्सिमल फिटिंग चेक करने के बाद, ड्राई फिट एक्सरे लेने के बाद, एंड ये चेक करने के बाद कि मार्जिन पे पूरा सीट हो रहा है, अंदर जा रहा है। उसके बाद हम पेशेंट को बोलेंगे कि आप 5 टाइम्स टैप 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 करो, ऐसे 5 टाइम्स टैप 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 करो इन स्टैटिक विदाउट मूविंग जॉ हेयर एंड देयर, जस्ट सेंटर में ऐसा जैसे आप बैक टीथ पे खाना खाते हो वैसे टैप 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 करो। ओके, आपको क्या पूछना है पेशेंट को कि डू यू फील वन साइड इज टचिंग मोर देन दी अदर, एक साइड ज़्यादा ऊंचा लग रहा है, एक साइड ज़्यादा पहले टच हो रहा है या जल्दी टच हो रहा है या ज़्यादा टच हो रहा है, ये वर्ड यूज़ करो। कि क्या आपको लग रहा है कि कोई एक साइड पहले टच हो रहा है, पहले ये यूज़ करो, पहले टच हो रहा है। ओके, टाइमिंग ऑफ कॉन्टैक्ट इज़ वेरी इंपॉर्टेंट। अगर पेशेंट बोलता है कि हाँ जिस तरफ आपने कैप लगाया उस तरफ मुझे ऐसा लग रहा है पहले टच हो रहा है और उसके बाद बाकी दांत टच हो रहे हैं, इट मीन्स कि आपका क्राउन हाई है, तो आपको डेफिनेटली उसको चेक करना है। ठीक है, पेशेंट को फिर वापस टैप 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 करने बोलो और पूछो ऊंचा कौन सा साइड लग रहा है, कौन सा ज़्यादा टच हो रहा है। ज़्यादा तो पहले हमने बोला पहले कौन सा टच हो रहा है, मतलब टाइमिंग ऑफ कॉन्टैक्ट। फिर हमने पूछा ज़्यादा कौन सा साइड टच हो रहा है, इट मीन्स एरिया ऑफ कॉन्टैक्ट कितना ज़्यादा है। तो अगर पेशेंट ने बोला है पहले ये साइड टच हो रहा है तो ऑब्वियसली ज़्यादा पे भी यही साइड बोलेगा। ओके, कुछ पेशेंट्स नहीं बोलते हैं, दैट्स ओके, हमें उसको छोड़ना नहीं है, वी हैव टू गो डीपर इनटू इट। ठीक है, सो व्हेन पेशेंट इज सेइंग कि हाँ मुझे थोड़ा ना एक जगह पे कॉन्टैक्ट ज़्यादा लग रहा है या मुझे ऐसा लग रहा है कि ये पहले टच हो रहा है, इट मीन्स पेशेंट इज सेंसिटिव, परसेप्शन अच्छा है पेशेंट का, तो हमें बेटर फीडबैक मिलेगा। इट्स अ गुड थिंग फॉर अस। एंड देन व्हाट वील डू, वील टेक अवर ब्लू पेपर विच इज़ 40 माइक्रॉन्स, विल टेक दिस मिलर्स फोर्सेप, इसको वैसलीन कोट करेंगे और उसके बाद पेपर लगाएंगे। अब पेपर लगाएंगे और पेपर लगाने के बाद वापस हम टैप 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 करने बोलेंगे। पॉज कर दो जब हाथ थक जाएगा तेरा तो। ठीक है, चलो स्टार्ट हो गया। ओके, सो वी हैव दिस बाइट पेपर जिसके ऊपर वैसलीन कोट किया है, एंड विल कीप इट इन द माउथ एंड विल टेल द पेशेंट टू टैप टैप टैप। व्हेन द पेशेंट टैप्स we will get some blue colored points, so we have to check, okay, where is my blue colored point coming, is it coming on the functional cusp or non-functional cusp. So functional cusp is buccal cusp of the mandible and functional cusp for upper is palatal cusps, and non-functional is lower lingual cusps and upper buccal cusp. So first we have to check the bad things. So the bad thing in the back side posterior dentition is any mark coming in static bite, any mark of the bite paper coming in the non-functional cusp. Okay, so any point you see on the non-functional cusp, like you here see a little bit point on the premolar and the molar buccal cusp tip, right? That point we have to first remove without doing anything to the crown. Only that point we have to first remove. Why? Because that is a non-functional cusp. Non-functional cusp tip, when it is touching the lower, the forces of chewing and forces on the tooth, they are actually traveling lateral, not vertical to the long axis, not parallel to the long axis. They are actually trying to go sideways. So that force vector is very high, and that is one of the major reasons why, because of this occlusal high point, there will be chipping of the cusp tip. So once we have adjusted the static point, then again we ask the patient tap 5 times, check, are you feeling better now? Definitely 94% of the patients will feel better once you have removed the non-functional cusp point. If the patient says no, still I feel it is high, then you check 40 micron paper, you take and you try to slide it out from the from this teeth. Okay, if it is not sliding out, it means the contact is higher than 40 micron. That is a good thing. Okay, it is tighter, it is much more tighter. That is why 40 micron paper is not coming out. So then you reduce the functional cusp tip. Okay, till before reducing non-functional cusp tip, non-functional ridge, we are not supposed to touch the functional cusp tip. So after non-functional cusp tip reduction, then we go on to functional cusp tip reduction. Even after non-functional reduction, patient says I am feeling that crown is high, then only go for the functional cusp tip and the central fossa also. So what we should see, at least one point in the center of the tooth and one point on either of the cusp. It is not required that you have a complete full array of points. It is not required that you have multiple points. More than 3 don't make a very big difference. If it is 2 or 3, it is good enough for a partially edentulous case. In FMRs, we say that 1 point per tooth per quadrant is also enough. So if in a FMR, your first premolar central fossa, second premolar central fossa, first molar central fossa and second molar central fossa, only one point is also coming, and same is there on the other side, that's also fine. You don't need to have lot of points. Okay, in the single tooth, when you are replacing, you try to have at least 2 to 3 points in that, so that chewing efficiency is maintained. Okay, don't blindly go and reduce everything blue what you see. You have to be very careful. Now once the patient is comfortable in static, we tell the patient to chew side to side. So how we do that? We tell the patient to chew side to side like this, like how I am doing in the articulator. And also we tell them first, so how we start is, first you bite on centric and then tell the patient to take it side to side, and the next what you tell the patient is open slightly, take the jaw on one side, close, and then come to center. So actually this is the main motion which the patient has to do, so that this is actually how we eat food. We don't eat food like this. Nobody eats food like this. What we do is we open the mouth, then we put food inside, then we take our jaw to one side, crush the food, and then take it to the center. So this is the movement actually we are looking for. And in this movement, in both these movements, center to side and side to center, in both these movements, ask the patient, are you feeling any obstruction to the movement of your jaw? Is the tooth giving any obstruction? Is there a free movement or any obstruction? If the patient says it's free movement, means there is less chance that dynamic extra points are there. Like in the dynamic movements, in the eccentric movements, it is little better. If the patient is telling you that yes, I feel it is not allowing me to fully move, or there is some problem, then definitely there is some eccentric point in the occlusion still, which has not got reduced with the after even checking the static. So then what we do is we take the paper 40 micron again, and we again tell the patient to do this chewing movement. We tell the patient same thing. We tell the patient, try to tear the paper, try to tear off the paper. So what the patient will do? Patient will actually grasp the paper and try to move it to the center and the side. and then again also tell them, keep the paper and tell them to do the same motions again. Okay, so for this we actually have to train the patient how to do that. So we have to remove our mask, come in front of the patient, and then show them in our mouth what we are asking them to do. So I am telling you, chew, open, take it on the side and chew, open, take it on one side and chew. Okay, this is first. Second is keep it in center and bite to the other side. So this is actually what we have to tell the patient, show the patient, and then we have to tell the patient to do this. Pause kar de. So once we have achieved all these points, we have reduced on the dynamic occlusion. Again we will check whether there is any line which is coming on the posterior. So there shouldn't be any line coming, not on the functional cusp tip, not on the functional ridges, outer inner slopes of the cusps, neither on the non-functional outer inner slopes, because there is no guidance which is provided by the posterior. Guidance is always provided by the anteriors, as anterior as possible. Okay, so if there is an open bite in the front, then if the canine is also an open bite, then first premolar will provide the guidance. If first premolar is also open bite, then second premolar will provide the guidance. So in those cases we have to be very careful and we have to keep it off the guidance. We cannot keep molars, any functional or non-functional cusp tip, ridge or slope having any line on the dynamic movements. If you see any smudge marks, any lines, you reduce that line. Okay, don't reduce the point of the functional cusp tip, don't run the burr on the central fossa, reduce everywhere else. Okay, try to reduce everywhere else, and then again ask the patient, do the movement, how are you feeling. So this has to be done repeated number of times, sometimes 10 times, 20 times. We keep doing this with the 40 micron. Okay, then we move on to the 12 micron. Now 12 micron, basically this paper is very thin, it is only colored on one side, so we have to keep it on the area where we are doing the tooth, where we are touching, that side should be the green color. So if you are doing upper tooth, you keep it like this. If you are doing lower tooth, you keep it like this. Okay, and then again you have to tell the patient, tap 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 and check, are you getting any non-functional cusp points, non-functional tip, cusp tip points with the green color, that again you reduce. So this 40 micron, if we have reduced, sometimes still little bit points are remaining, they are can be caught by the 12 micron. Okay, and again you tell the same movements by dynamic and check whether there is any green line coming in the dynamic movements, again you reduce it. Now what we want to make sure is that if we are doing 7 number teeth, 2 7 3 7 4 7 or 1 7, if we are doing a crown on that tooth or only on that tooth, we don't want high pressure on that tooth, because those teeth are more closer to the lever. The lever is the TMJ. So more closer to the TMJ that tooth is, higher the pressure it will have. So we have to make sure that it is slightly lesser in contact than the other teeth, even on static. Okay, even in 6 in the distal cusp tip you can do this. Okay, so what I try to do is, I tell the patient to bite, I check the points with the 12 micron, I slightly round it off, curve it off. Okay, so that a lot of pressure is not coming with the 12 micron also, but I tell the patient to bite and then I slide this outwards. Okay, so you may have to cut it slightly, like you have to reduce the thickness of this paper, make it very thin, and then only in that tooth area you have to keep it, and then tell the patient to bite normally and then slide it out. If your paper is 12 micron paper is sliding out with a little bit of friction, okay, with a little bit of friction, then it is very good. If it is tightly held on light bite, then it is not good. Okay, if it is tightly held on light bite, it is not good. If your paper is getting slightly with little bit of pressure, slight, like you have to pull it, and when you pull you will feel slightly resistance, but it does come out, that's the best. Okay, that means that the contact is slightly less than 12 microns on static. And then ask the patient to bite tightly. When you tell the patient to bite tightly, the paper should not come out. That means 12 micron on tight bite is definitely there. So this will never lead to infra-occlusion. If we are doing occlusal reduction and we see that on our 40 micron paper when the patient is biting, the paper is coming out without resistance, very easily it is coming out. It means that our contact is, there is an infra-occlusion. There is a space of 40 microns, that is why 40 micron is coming out. That is not acceptable. Okay, what is acceptable is that 12 micron should pass. So now as closer to the lever as we move, means if we are doing on 7, this paper, 12 micron paper, should easily pass out on light bite. Okay, and on heavy bite, like tight biting, slight resistance should be felt, but it should come out. On 6th tooth, it should come out, it should easily pass from on light bite, and on heavy bite it should not pass out very easily. It should not pass out. Okay, so then we have achieved a slight distance between the upper and the lower teeth, a slight distance of maybe around 6, 8 or maximum 10 microns on static occlusion, but definitely not more than 12 microns. This does not lead to infra-occlusion also. This does not lead to untoward supra-eruption of the tooth. Okay, and it will give you a better result in the long term. So yeah, that's usually this. Sometimes it is not possible to do all these things before the cap fitting appointment. So what we have to do is, we have to definitely adjust on the 40 micron paper on the cap fixing appointment. That we have to make sure that before doing the fixing of the cap inside the mouth, 40 micron paper, all protocol should be completed, static and dynamic. Then we have to take our straight handpiece, grey and yellow colored zirconia polishing burr. We have to first use the grey burr, then we have to use the yellow burr, and we can achieve a very good mechanical finish of the occlusal surface. If and then we can go ahead and fix the crown. Then we call the patient again after some days, 1, 2, 3 days, maximum 5 days, and then again we do the check with the 12 micron paper. Now with 12 micron, again we adjust a little bit when required, and then again we polish it with the intraoral zirconia polisher, which are the green color and the beige peach color, green color and peach color from Eve or from Diatec. We can use that, and we can polish the zirconia crown to a high polish. Okay, so yeah, we'll follow this.